and it's getting less and less and less. Why is your body demanding more in any of these states? Shock. It's sick. There is an insult to the system. I don't care which shock. Something has happened. You've had a traumatic injury. You're bleeding out. You've had tension pneumothorax. There is an insult to the system. I've got septic. I've got a bad bacteria. Inflammation. There's an insult to the system, and it leads down this cascade that gets to shock. Does it have to get there?
No.
It doesn't. How do we stop it? What's the first thing? And this is y'all's job. You need to recognize and assess before we do what? How do I know I need IV? What's their blood pressure? How do I know they're bleeding? I ain't looked at them. They still got all their clothes on. Pulses times 4 are intact. They got their combat boots on. You're an idiot. And I know y'all have laughed at me every time I've said this, and I don't even remember where I heard this. This is the whole premise for shock. I don't care why you're not getting oxygen where it needs to go. Maybe because your blood's flowing out. Maybe because you've got an obstruction. So there's two different things that determine how much oxygen gets to the system, right? What part is this? It's the respiratory part. How much oxygen do we have, period? If you ain't got no hemoglobin, then that's bad. What is hemoglobin? Why is that important? It's what the oxygen attaches to. You got the little concave thing, and you have 4 little life rafts on it. Those life rafts are hemoglobin, right? If you don't have an open airway, you're not getting any oxygen in. And what is the breathing part of this? That's the actual exchange, right? If I'm not getting any exchange, oxygen is not getting out, CO2 is not, oxygen's not getting in, CO2 is not getting out. What if we're in an enclosed space and the FiO2 is like 5? What's going to start dropping? Your oxygen content. Now, when we're talking about shock for this lecture, and I know I don't say this very often, we are assuming that is intact. We are assuming we have an intact respiratory system. That's not what we're focused on. What is this? Huh? What's the definition of shock? Hypo. What is this? Perfusion. This is your cardiac output. This is the amount of blood that's being pumped out to the body. This is it. There ain't nothing else that's going to get out but that amount. This is the amount we have to do what to all the cells? Perfuse. Hypoperfusion. I don't have enough. Cardiac output. If my cardiac output is low, y'all just answered the question a minute ago, what's my perfusion status? It's in the toilet. The different types of shock, still, you wind up at home, but everybody taking a different side street. Now, guys, we need to understand this globally. I'm not asking you for hemodynamic numbers. Hold on. That being said, I know Mr. Beret mentioned a Swan-Ganz catheter, and a lot of y'all were like, I don't know what that is. Here's the thing, and y'all know I went to nursing school in 2010, and I worked at Vandy in the ICU. The trauma ICU was the only place that used it because the doctor liked it. There are very, very few places that use them now. I know Tenova does. Because guess what? You can insert this sexy thing and it's hanging out the side. If you don't have a nurse that knows how to shoot the numbers, Okay, your doc went in there and exposed. It is a huge catheter. It goes all up in here, and if you get some bacteria in there, what is it? It's game over. They have found it is too invasive, too specialized. You need, look, it took me 2 days worth of class to figure out how to shoot those numbers. And then if you leave the little balloon wedged in your pulmonary capillaries, you just killed the baby. Yeah, Bye-bye. That's why we don't put them in. Y'all seen central lines, right? We can get a central venous pressure off of that. And it's worth its weight in gold. Central venous pressure measures preload, which is the amount of blood that drops in where? The right atrium. This is the whole amount that I've got that's going to go through the heart and come out of it, which is what? Cardiac output. If this is cut in half, output is what? Cut in half. Do you see how all of this relates? Guys, if you're at Tenova, you might see one. And it's kind of cool. I don't care. If they have in a central line, we can monitor CVP off of it. I think the normal number is 2 to 8, so that's preload, right? What if your CVP is 15? What's going on? Too much volume. Oh, we gave Meemaw 6 bags of fluid. Breath sounds are going to hear what? Crackles. Blood pressure is going to be what? Elevated. What if it's 1? Not enough. What can cause that? Hypovolemia, which a lot of things can cause that. Dehydration. Hemorrhage. Do you see what I'm telling you? Guys, y'all are figuring out how I teach it. I want you to know the whole forest, and we're going to take specific trees out. I don't want you to focus on those numbers. Guys, these questions are mine at this point. Mine and Dr. Wilkes. And we worked really hard. And even now, like last time that y'all took that test, I'm refining them based off the results. Because I want to give you guys the best chance to get through NCLEX as we can. They're not perfect, but they're a lot better than they used to be. That's why I can tell you with certainty, this is what I want you to know. How do we figure out what cardiac output is without the numbers? What makes it up? We can figure this number out, right? Now, stroke volume is what? The amount that's ejected what? Right. Heart rate, we know what that is. Now, stroke volume. What did we just say this is? If my preload's cut in half, my stroke volume's cut in half. My cardiac output, do you see where how this all plays in? Guys, this is hemodynamics. That's all this is. What is this patient going to look like? This is cut in half. I don't care why. Possibly. Pale, cyanotic. What about their skin condition? Huh? Maybe mottled. What about clammy? Huh? Diaphoretic. What about their heart rate? Going to be usually increased. How long can it stay increased? Not forever. What about their breathing? Tachypnea. What do all those sound like? Sympathetic, parasympathetic. Sympathetic nervous system. So, I told y'all I'm old, I'm running from the bear, heart rate's going to go up, breathing's going to go up. In every type of shock, your body is being attacked. There's an insult to the system, and it is going to go into fight or flight to save itself. That's why you see every sign and symptom. That's why you get your heart rate jacks up. Sympathetic nervous system is in control, right? So you know that these signs and symptoms are based off of that. What if the patient has bad cardiomegaly? Like their contractility is not good. That's going to affect stroke volume. That's going to affect cardiac what's that last word? Resistance. This is the pressure the heart has to beat against. And that's all about the container. This is just a different, this is the same thing. Contractility, preload, how much am I getting in? How hard am I going to have to beat to get it out? So if this is sky high, what's going to happen sooner or later? Your heart's going to fail. How many times have y'all heard, what's the map? Why is that important?
Organ perfusion.
Guys, this is organ perfusion. Can we figure this out? Sure can. Even if it don't show it on your monitor, you can figure it out, guys. I don't know the formula. I'd have to look it up. Mean arterial pressure. That means, and it does, if your map is 50, what's normal?
65.
At least 60 to 65. If it's 40, what's your cardiac output? Horrible. It doesn't matter why. You just figured all that out. That's why map is so important. This is what is getting to the organs. Now, everybody finna go in the shop. Watch, I'm looking at y'all's face. Y'all remember the Krebs cycle? We ain't going through that, I know that. So what was the end product? 36 ATP, happy cells, yay. Right. What happens when we flip the script and we ain't got no oxygen? Boo, yeah. Anybody here marathon runners? Or run every now and then? Why are your muscles sore? Because I don't care how good of shape you're in. If you run 50,000 million miles, sooner or later, they're going to have to switch to anaerobic. And they have a buildup of what? So then you have back cramps for several days. They tell you to drink a lot of water. So your perfusion is going down for some reason. Your oxygen is going down. The cells are trying to save themselves, right? So they switch to anaerobic. What is the result of the anaerobic? We said 36 ATP in a happy cell is 2 ATP and what else? Lactic acid. So, my lactic acid is building up, and I've got decreased ATP. What starts to happen into the cells? I'm getting more and more acidic. Let's say it's 7.2 for the pH. The cells are beginning to leak. They're becoming permeable. They can't stand this environment. They're also starting to die. What's the normal thing? What's the normal electrolyte in the cells?
Sodium.
And what's outside?
Potassium is outside. I mean, no, sodium is outside.
Sodium's outside, potassium's inside. Alright. So, normal outside, normal inside. How do we get them back and forth normally? Sodium, potassium, pump. Guess what fails? That does. This goes out, and that goes in. It ain't supposed to be there. So, I'm trying to think how to word this. You remember when we talked about hypertonic, hypotonic, isotonic? Basically, all I want you to remember about this, and I promise this has a reason, water follows stuff. Is that fair?
Yeah.
Like if I got this much, and this is Mama's sweet tea, right? She put, see, this solves the hypoglycemic for every diabetic ever made.
So I like this much sugar, I don't like that much. My mom comes in and puts this much sugar. This is now a hypertonic solution because you got all the stuff. If there was water out here, it would suck it up in there. What did I just say went in the cell? Salt, water follows what? Salt. I ain't even talking about the potassium yet. I got all this salt in here. Water's going to start to come in. What's going to happen to the cell? My sodium potassium pump has failed. My potassium is out here. My sodium's in here. This cell is going to burst. Now let's talk about the potassium. Acidosis goes, the pH goes down. Potassium goes what? Up. What is that lethal to? The heart. When you hear potassium, I want you to think heart. Does anybody know what sodium is? Brain and muscles. Because a lot of times if somebody's sodium is so low or so high, you'll see seizures. So, I have switched to anaerobic. I'm building lactic acid. My sodium potassium pump has failed. I'm getting hyperkalemic, acidotic. Sooner or later, what's going to happen? You're going to die. If we can stop it up here, this is what saves the patient. How can we stop it? Fix the problem. Treat the cause. If somebody's hemorrhaging and I give them 60 bags of crystalloid, you're going to have pink Kool-Aid. Does pink Kool-Aid transport oxygen? Nope. Now, you give them a volume expander so that they don't die right off, but sooner or later somebody's hemorrhaging, you have to do what? Give them blood. What if they're septic? You got to give them what? Antibiotics. If they got a tension neuro and it's obstructive, you got to do what? Each one of these different shocks can have a little bit of different signs and symptoms, but they all go back to affecting what at the end of the day? Cardiac output. You guys see why I'm telling you this? Guys, this is the global picture of 90% of the patients you're going to see in some shape or fashion. Now, this ain't NICU. That's different. You might tell me, Ms. Horton, I'm going to work in L&D. You think they're not going to have, what is it at Tanoba, a code crimson? Which is a mass transfusion, which is what? We've got a hemorrhage up on the OB floor. And you're going to see all the nurses and you're going, I don't know what to do. Don't throw no babies out. Where's my clinical? Yes, ma'am.
Okay, so how come I got lost in the anaerobic? Like, what does that mean?
There's no oxygen. So, normally, aerobic, because if you remember the Krebs cycle, oxygen is in there. And at the very end of it, it has been, it is the metabolism of glucose, right? At the very end, is turned into energy. Without that oxygen, I can't make all of that. And I have to shift to something really bad that's going to give me 2 ATP versus 36. And this byproduct that's never made unless I don't have oxygen. That's when you shift from aerobic to anaerobic. Why are they going that way? They're not getting oxygen for some reason. What's the definition of shock? Hypoperfusion. Oxygen is not getting to the tissues, is not getting to the cells. It doesn't matter the reason. Does that make sense? That is the whole premise of shock. You have lost your oxygen in this normal cascade of how it's supposed to go. Your body tries to save itself, and it works for a little while, but it can't live in that state. We like homeostasis, not a pH of 6.2. That's not compatible with life. Why did I write that? Some have some of these. Every different shock patient is not going to look the same, but a lot of them are going to have these same signs and symptoms. Tachypnea, hypotension, tachycardia. The skin changes for each different shock is a little bit different. What is this? Now it's not none, it's decreased. What is the word for no urine output? Anuria. What about cat refill? It's prolonged. What's normal? Within less about 2 or 3 seconds. So if you do cat refill, and mine's probably 8 right now, and it's prolonged, what does that mean about cardiac output? It's not good. Now guys, take that with a grain of salt. On children, I don't even take a blood pressure on 2-year-old. One, they're going to scream and cry, and they're not going to do that unless you tell them to show them your sexy muscles, and then they put their arm up like this. How accurate is that blood pressure? It's not. How many cheeseburgers, fried Twinkies, and fried Oreos do you think a 2-year-old, hopefully, has had at this point? Definitely not as many as I have. So when you get to be an adult, you have cardiac problems, you have COPD. It is still a reliable indicator of perfusion, but it's not as reliable as it is a pediatric patient. If I've got a child less than 5, I ain't gonna pull that blood pressure cuff out. We already said what causes the different signs and symptoms is whatever's causing the shock. And the variety is very important. Why? It tells you how to treat the cause. And this is what I said a different minute. We're all gonna wind up in shock. We all gonna wind up at home, but we all took different side streets and had a competition to see who can get there first. This is a perfusion triangle. What is the definition of shock? Hypoperfusion globally, right? So what makes up our perfusion? The pump, the pipes, and the volume. You notice I did not say blood, right? So, if something is affecting your perfusion, it is affecting one of these 3. For every different kind of shock, it will relate back to one of these 3. This is it. This is what determines your perfusion. Now, 1, 2, 3, 4. There are 4 different types of shock, but you see there are little offshoots to these. Don't let that confuse you, because when we explain them, it will make sense as to why it's distributive shock. What did we say that tension pneumo was? Obstructive. Something is obstructing your flow, right? And that surely does. What about pericardial tamponade? How? Right. So you got a hole and something's leaking out there, right? So every time the heart beats, a little bit more fluid gets out there, a little bit more fluid, and sooner or later my heart's, and I can't beat. There's no forward flow. Is that a cardiac problem? No, it's not a heart attack. It's not a problem with the muscle. It is something outside the heart. If it was a heart attack, what kind of shock is it? Do you see what I'm telling you? And girl, they used to have all these separate. Oh my God. And then they had a hypoglycemic shock, burn shock. Anyway, we're going to get into these specifically. All right, so we said the triangle I know is up there. Which one of the 3 does it affect? The pump. Guys, you can have the best water system in the world. If you don't have a pump, you're not going to get water anywhere. So, cardiogenic shock. Cardiac output is nothing. If I don't have a pump, I'm not going to have volume and perfusion go anywhere. What can cause this? MI is a big one. What else? Trauma. Well, no, I'm sorry, that is wrong. That's going to be not the heart. That's going to be obstructive, right? Congestive heart failure, because if their BNP is 50,000, their heart is not functioning correctly, right? And that's a problem inside the heart with itself. So I know we said the tachycardia, the tachypnea, and all that stuff. What is specific to cardiogenic shock that you won't see in other ones? Chest pain, right? If they're having an MI, they might tell you, hey, that elephant's sitting on my chest. I feel pressure. I feel pain. In other types of shock, they will be tachypnic, but I feel like the more times I've seen this, they say, oh, I can't breathe. I really can't breathe. If they're having an MI, that's associated, right? They might have nausea and vomiting. Let's say it's caused from congestive heart failure. What if it's left-sided heart failure? Pulmonary edema. What if it's right-sided? It's in the peripheral. Something is happening to the pump. What assessment do you do? Definitely vital signs, blood pressure, pulse rate, SpO2, what else? Labs, EKG is very important. Yes, we'll get to the the test in just a second. Has anybody ever heard or seen, and if you get the chance to see this, you need to go in there, they call it a TEE, and they'll do it bedside. Transesophageal echocardiogram. They call it the bubble test too. They're going in there to see how the left ventricle is functioning, right? It's still an echocardiogram, but it's not as, like, have y'all ever read the echo report? Oh my God, it's like a research paper. I scan all the way down to the conclusion and discussion. I don't know what they're saying. Guys, I want to mention this, and I know I cannot seem to capture this color. It's not pale. It's not cyanotic. Looking. It's almost the color of her shirt. It is a gray. And y'all, and I swear for God, y'all gonna see it and you're gonna be like, oh, that's a heart problem. And once you see it, you'll never forget it. There's nothing that's that color. And you can bet your bottom dollar they're either having an MI or going into cardiogenic shock for some other reason. And it is this bluish gray color, but it's also what? Mottled. Did I say pale? No. What's pale? Hypovolemia usually is hemorrhage. Oh, we had the looks like. What else might they look like? What did you say? That might be Levine sign. Cardiac starts with a D. Dysrhythmia. Right? How many of your patients with an MI go into a funky rhythm and then die? Can VTAC cause cardiogenic shock? Yes, it can. Very quickly. We need to treat the cause. Do you give the patient with an MI the same thing as you do somebody in congestive heart failure? I certainly hope not. IV bolus, maybe. If they've got bad congestive heart failure, you're probably still gonna give them a bolus, but you're gonna have to be careful. Meds to treat the cause. If they're having a heart attack, what meds are we gonna give them? Nitroglycerin, morphine maybe, aspirin, oxygen, and depending on all the contradiction or what contraindications, you might give them what? A clot buster. They're gonna go get a cardiac cath. You might have to do some electrolyte correction. Here are the tests we talked about: CBC, ABGs, metabolic panel, troponin. What is this looking at? Heart failure. Every patient that they even suspect is in shock is gonna get a lactic acid drawn. What's important about that when you draw it? You need to put it on ice. So one day we had a bad septic patient come in, they drew blood, I wasn't drawing the blood, and so somebody said, hey, did you get the ice? And the girl's like, yeah, I'm gonna go get it. Girl, I had left the room, that's the gray tube. 10 minutes later, I come back in and what? You know, it accidentally went in the garbage. I don't know how that got in there. Guys, it's worthless. You have to put it on ice. Everywhere I've ever worked is great. Have y'all ever worked anywhere else was it a different color? There is a chart at the end of this. This is important in every different kinds of shock because it's going to be first line vasopressors and then the second alternative. You might tell me, Miss Lorna, I'm not going to write the prescription. I know you're not, but you can have it what? Ready. And you can understand why you're giving it. I'm fisting to pick on him. Michael, what did you tell me happened? He's one of my former students that's sitting in the back. He's being quiet because I told him he can't interject. What happened the other day at the nurse's station when the medical students were out there with you?
They were
You speak louder.
They're describing the effects of norepinephrine versus epi, their uses on different pathologies.
And what? They started talking about what? The receptor sites. And then he starts explaining it to the med students. And the attending was sitting there staring at him like, guys, what? Right? Guys, I wouldn't keep harping on things if they weren't important. So, cardiogenic shock, norepinephrine. Does anybody know which receptor sites this one hits? Heavy. Alpha 1, which is vasoconstriction. Pump pipes or volume. The container. This affects my pipes. So, if all my vasculature dilates to oh my God, what's your blood pressure going to do? Drop. If I constrict it in to oh my God, your blood pressure is going to go up. So I tried to go get some balloons this morning, but it didn't work. And I was going to give y'all a straw and a coffee stir. And see who can inflate the balloon first. How much pressure is going through that coffee stir? A lot. And through the straw is normal. In cardiogenic shock, why wouldn't I want to speed their heart rate up? It's already sick. So I'm going to give them epi, right? No. Alpha 1. It does, guys, it does have a little bit of beta 1 effect, but not much. And it has no beta 2, right? Why would I give it to an asthma patient when I've got a drug that hits all three? Do you see what I'm telling you? And guys, every semester when I teach this, I go back online to make sure nothing has changed, because it changes on a dime. For cardiogenic shock, norepinephrine is the first line med. I'm telling you right now, you're gonna be getting questions on my test that say, this is what you got, what are you gonna give? That case scenario, if you haven't looked at it, that's all it is. That will help you with the test. Dobutamine, it's got beta 1 and beta 2 and just a smidge of alpha 1. Guys, there's not a lot of places that use dopamine anymore unless it is a cost issue. This is not the greatest drug in the world, and it jacks your heart rate up. This is not what I want to be giving to somebody who is in congestive heart failure or who's having a heart attack. Aspirin, Lovenox, and Lasix. What time do we get out of here? What?
She said we get out.
You need to stop. This is on, I know this is on the shop too. But this is just showing you how it's set up. Cardiogenic or epi. A lot of alpha 1, a little bit of beta 1. Dobutamine, beta 1 and beta 2. Septic shock, norepinephrine. I know we haven't talked about septic shock, we will tomorrow, but let's see if this makes sense. Does anybody know the umbrella septic shock falls under? What is so, did I say obstructive? No, something is obstructing this flow. What is distributed? Fluid is getting distributed to places it ain't supposed to go. For some reason. There's 3 different reasons. But what is septic shock? You have to have septic shock, you have to have a source of, period. It can't be septic shock without that infection. All the histamines, all the inflammatory responses, all this stuff, there's an insult to the system. What happens to the capillaries? They start becoming permeable and leaking. Where does that fluid go? Out of the vasculature. And it makes your vessels dilate. So you got insult to injury. I got my fluid going out and my pipes are dilating. So their blood pressure is going to go in the toilet. So if my fluid is being distributed to places I don't want it to go, if I increase the heart rate, is that going to help? What if I can decrease my container? Back down. Which one am I going to choose? Something that hits alpha 1. Do you see what I'm telling you? These are important. Septic shock is distributed, norepi and vasopressin. Hypovolemic. Why don't we give them vasopressor to start off with? If you ain't got no volume in there, what you squeezing on? Nothing. If all your blood is on the floor, you can squeeze all day and it ain't gonna make no difference. Fluid resuscitation, treat the problem. It's either hemorrhagic or not. Either you bleeding or you ain't bleeding. If they are bleeding, multi-system trauma, what do I need to jump to early? Blood. Blood products. Is it just packed red blood cells? That's not all that's floating around in y'all's vessels. Plasma. Platelets. Which umbrella does anaphylactic fall under? Distributive. So what does a patient in anaphylaxis look like? Wheezing, angioedema. Why are they getting that edema? Fluid is going places it's not supposed to be. What else? They're itchy. Hives. What's the other word for hives? Urticaria. Now, you see it's not, norepi's not first. Why? What receptor sites epi? Huh? Specifically what? Your airway. How many hearts do you have? One. How many lungs? Two. Beta 1 is heart, beta 2 is the lungs. Why would I use, now, if they're hypotensive, I still need the alpha 1, right? What if I had a drug that hit all three? And that's epinephrine. Now you might not want their heart rate to go up, but then none of the other vasopressors affect the lungs. Guys, if somebody's in anaphylactic shock, what's the first thing you do? You give them an IM injection of epinephrine. It's that important. And if it's that bad, hypotension has developed, now how are we going to give it? IV. Alpha 1, it causes the vasoconstriction. It is distributive shock. But they're also wheezing like hell, and they're almost completely shut down in their lungs. You finna have insult to injury. You ain't got no perfusion, you ain't got no cardiac output, and I'm not getting oxygen in. Alpha 1 to constrict down the container. Beta 1 to help the heart beat better. Beta 2 to open up your bronchiole. If that ain't working good enough, they might add that, but it's not first. What is all this doing between first and second and first and second? It's treating the cause. It's just like septic. You got to give them antibiotics. You can throw everything at them under the sink, and if you don't give them their antibiotics, they're going to die. So the first thing you want to do for a septic patient is what? Before the antibiotics, if you can, culture. Draw your blood cultures, guys. It's very important because we're going to give them this broad spectrum, and we're going to do it. We're going to start the broad spectrum. We're going to send off what? And it's going to come back, and now we can narrow it down. Draw your blood cultures, give the antibiotics, and we will give them a fluid bolus. We will start vasopressors, but there's an order of things. You're treating the cause. All right, we got a few minutes. Is anybody completely lost? Guys, if you don't tell me the questions you have, I don't know. What's muddy? Yes, ma'am.
So for like lactic acid, are we looking for muscle breakdown or cell death? What is that about?
So the lactic acid is what's being produced. You know how bad the anaerobic has kicked in. Like if your lactic is going up, how much anaerobic metabolism is going on? A lot. So let's say a patient comes in, you draw all these things, and their lactic acid is 10. So you've done all the things, we've done the resuscitation, and 2 hours later it's 12. Has our resuscitation been effective? No. That's how we use that. So when they come in, we draw this, and it's like, oh my God, or it's, oh my God. So what if it's 6? We're going what? In the right direction, because it's dropping. So that means my resuscitation has been successful. If I can add to that, they came in and they're anuric, and now they're making a little bit, and their lactic acid is dropping. Are we going the right direction, wrong direction? Right direction. Guys, this is how you need to think. How can I tell? Did I say anything about a Swan-Ganz or a CV? No. All you need is that Foley, and sometimes you do need lab, to tell you how your patient's doing. When they came in, they were saying that President Roosevelt was in the office and they were anxious and restless and their skin looked terrible and they're diaphoretic, and now they've pinked up and they're A&O times 2. We ain't back to baseline yet, but we're a lot better. How do you know what you're doing is working? And I asked all y'all during SIM pretty much, what's the definition of insanity? Doing the same thing over and over and expecting a different outcome. If what you're doing is not working, then change something, right? I know we've got first and second line vasopressors, but if they're not working, we got to jump to something different. It ain't all cookie cutout here. There are things that we have to do every time the same way, yes. But some of these parameters can change if they've got different results that are coming back. Does that make sense? Yes, ma'am.
With the last 30 minutes, can you go over your respiratory PowerPoint?
Does anybody else have any questions about shock? Hey guys, you know this is going to be quick. I can't get through it without that. What is the respiratory system's job? Oxygen in, carbon dioxide out. So, we breathe and our cells breathe. Is that fair? They got to get oxygen in, they got to get CO2 out, which is considered what? A waste product. And then we have to get it out of the body. That is all the respiratory system is responsible for. Where does it occur? At the alveoli. Right down here. If oxygen goes in, carbon dioxide goes out. Carbon dioxide is breathed out. Respiratory failure. We just talked about this. Either I ain't getting oxygen in or what? I ain't getting CO2 out. Hypoxemia, low oxygen in the blood. Hypercapnia, too much carbon dioxide in the blood. These are the parameters that I have to, hold on. What happened? PaO2 less than 60, PaCO2 greater than 50, pH less than 7.3. Have any of y'all been around when somebody said, hey, go get the iStat? Y'all know what that is? It's really cool. It's a little machine that's handheld, and it's got, I don't even know how many different types of cartridges, but they've got one that'll do cardiac enzymes, they've got one that's basically a CMP, and they've got one that does an ABG. So, now, is it 100% as good as sending that to the lab? It's not. But let me show you how we do this. We put 1 milliliter of blood, a little bit of blood, push it in there, and about a minute later, beep, there you go. Immediate values. And you will see these numbers. What do I need to keep in mind with this PaO2? Are they on oxygen? Are they on the ventilator? That needs to be kept in mind. Like if your patient's on a nasal cannula and you're like, oh, it's 60. It's 60 with extra added oxygen. So there still might be a problem. Do you see what I'm telling you? Did I say respiratory distress? No, I did not. Dyspnea, respiratory distress, respiratory failure, they ain't but one left. Respiratory arrest. If you don't stop that, respiratory failure is going to happen into what? Respiratory arrest. So they are going to be short of breath. They might be cyanotic. Do you think respiratory distress usually has an altered level of consciousness? Not unless it's bad and fixing to get right here. Tachycardia. Why is their heart beating fast? They ain't got no, it's trying to compensate. The body's trying to save itself. There's an insult to the system, right? accessory muscles. Y'all ever seen it? Where are we talking about? I sure ain't hot, so where? Intercostals, like in her. Where else? So supraclavicular, right here, which is what? Subclavicular. You might see it right here, and there. What's right here? Your trachea, tracheal tugging, guys. That's bad. If they're, why are they using accessory muscles? They are using every cell in their body to try to draw more oxygen in. If you see all that, and especially with babies, and my brother could always do this, I never could, the nasal flaring, that's an accessory muscle used. And for infants and babies, do y'all know the sound they make when they're in bad shape? Grunting. And then they'll start that. That's their altered level of consciousness right there. You better do something. The assessment is pretty much the same. You're going to do all your vital signs, SpO2, cardiac monitoring. Why am I going to put them on the telemetry monitor? Can you look at that rhythm strip that's running and tell if their oxygen is low? How? If the ST is low, their oxygen is low. Girl, that light bulb just came on. Look at that. You're also going to do what else? You're going to run a EKG. If they had an MI, might that be causing the respiratory failure? With an altered level of consciousness, that makes it a priority patient. Looking at what? Airway. I can't control my own airway. You're going to walk in and they're halfway unconscious and they have snoring, gurgling respirations, which means what? They've got secretions in the back of their throat and they can no longer control their airway. You will intubate them. I know you heard these terms and you probably have seen it. Has anybody got family members or whatever that has sleep apnea and they sleep with the little thing over their nose? So it's either BiPAP or CPAP, and it's right here, or it's got the full face monstrosity. That's the one you're going to see in the ER and ICU. Guys, if you have a patient that has ICU delirium, and I've had them say this more than one time, they told me there's an octopus on their face and they are terrified. Guys, they got ICU delirium. They're not with it. He was absolutely terrified all day long. He said there is an octopus on my, and it looks like an octopus that's on his face, and it's shoving air down in his lungs. How do I minimize oxygen demand? If I have you up running, your heart rate's going to go, oxygen demand's going to go up. I don't want you running. I want you to rest. Why do we give them sedation and put them on the ventilator? You can't just let your lungs rest. I ain't gonna breathe for 5 minutes. No, that don't work. What else plays into this? What if it's a bad trauma that's caused respiratory failure, but I'm still awake? Pain. Pain makes your heart rate go, increases oxygen demand. Pain is whatever the patient says it is. Don't be judgmental, Judy, or Jimmy, or Jethro. I like them. Why am I treating a fever? Makes your heart rate go up. Test, ABGs, chest x-ray, CBC, EKG, and a Does anybody know what a VQ lung scan looks for? And it shows you if there's a clot too. There's also something called a CTA, computer, I can't pronounce that word, angiography. It's looking for a PE as well, if they tell you that that's where your patient's going. Guys, this number is not set in stone. But if I'm distressed, I might have some of these. Agitation and anxiety is considered an altered level of consciousness, but it's not to this effect. This patient will damn near not be A&O times nothing. Their respiratory rate will either be through the roof or what? So it's going to be real high at first, but down here it's going to start what? Dropping. They can't maintain a 60 breath per minute. Retractions, modeling, severe air hunger. Why are they getting bradycardic? Their heart's starting to what? Fail. They're tachycardic here. They got delayed cap refill. They might be pale. They might be cyanotic. But now we've got to modeling. Modeling means our perfusion is what? Bad. Now what? My heart's failing, my lungs are failing, and my blood pressure's going to. Cardiac output is going to. Yes, ma'am.
So, if any of these isn't solved, it can lead to one another.
Yep. Once y'all have worked different places long enough, that patient's gonna come through and you're gonna be like, you better go see that patient. I do right now. Guys, I'm not saying I know all this stuff, but I have seen a lot of patients go from respiratory distress to respiratory failure. And I was at a hospital, they didn't know me. It shouldn't have made a difference. I came in and gave a report and nobody's listening to me, and I was like, that patient is fixing to go into respiratory failure. Nobody's listening to me. I stood there as long as I could, and I waited until the patient stopped breathing, and I started begging him. I said, can somebody fucking come help me take care of my patient? Listen to the people that are talking to you. And it might be your tech who's in nursing school. The respiratory has arrested, it's gone. You're not breathing, you're apneic. Cyanosis, no air movement, and you ain't gonna be responsive if you're in respiratory arrest. You ain't gonna be anxious either. I know all of this looks confusing, but it boils down to either you're not getting air in and out, or you're not getting blood where it needs to go, right? If I've got a pulmonary embolism, which one is that going to affect? Perfusion. Am I having any trouble breathing in my airway? No, it's patent. What kind of shock? Obstructive. I have a mechanical, girl, get it. I have a mechanical obstruction. So alveoli are well ventilated. I'm getting air in and out, but I ain't getting no perfusion. Here, alveoli are not being ventilated, and the blood's going everywhere it needs to, but it ain't got no oxygen down in there. So it's not getting anything across the alveolar membrane. That was the picture I showed you before. So, tell me whether this is perfusion or ventilation. Blood does not go to parts of the lungs that have oxygen. That's perfusion. Blood goes to parts of the lungs that do not have oxygen. Ventilation. Ventilation is getting oxygen in and out. Perfusion is getting the blood in there. You got all the oxygen you want, but it can't get on the other side of that PE, right? Does every patient that has any of these things that cause it develop ARDS? No. We don't know why patients get ARDS. Guys, if they truly develop ARDS, there's a 50% mortality rate. I've had patients in the MI for a month, and every day we are battling to keep this patient alive, and about 50% of the times, it didn't turn out the way we wanted it to. Despite, look, we were doing everything under the sun. So something causes an injury to the system. There is an insult to the system. Burn, sepsis. Sepsis mounts what? An inflammatory response. If you get burned, does that mount an inflammatory? It does. Bad trauma, it's still an inflammatory response. Why near drowning? What's the difference between near drowning and drowning? You dead, you're not dead. But why near drowning? What goes in your lungs? Is it supposed to be in there? And let's say you're at the pond. Now what's, yeah, you got cow poop.
You got other things in the water.
Sepsis. Smoke inhalation. That damages what? Your lungs. It sets up a massive inflammatory response. Why this? Now I ain't talking about one unit. Massive transfusion protocol, I think, is 32 units of packed red cells, and it's got plasma and cryo precipitate. It's a lot. Why would that cause this? Guys, is getting blood just What'd you say?
The specific stuff in the blood transfusions, that's why.
Is this blood truly our blood? It is not. Even if you type in cross-match, it's not our blood. And your body might say, what? Hey, yeah, what the hell is this? That ain't me. And it's going to mount an inflammatory response. Autoimmune system, your cells attack what? You. Anytime else that you have an inflammatory response, your cells attack other things, antigens, right? Imagine if you got 32 units of uncross-matched trauma blood. That ain't even your type. You don't even like it. Your body is going to mount an usually if they do that, if the patient lives, you know what they'll give them? Prophylactically. What would you give for an allergic reaction? Benadryl? Pepsid? They probably won't go to Epi. Maybe not. Depends on how bad it is. Huh? Surfactant?
Yeah.
What else? What do we get for just allergic reactions a lot of times? Steroids. What do steroids do? How do they work? They're anti-inflammatories. Guys, this is a malfunction where? At the alveolar capillary junction. Your alveoli get filled with what? Crap, mucus, fluid, waste product. Can you breathe through crap? No, you cannot. These patients literally drowned in front of you. Guys, this is not, the patient don't come in from the hospital, to the hospital, from the fire scene, smoke inhalation, they got ARDS. No. When does this develop? It takes at least a few days. And it's like I said, every patient that has these incidents, they don't develop ARDS. We don't know why. tachypnea, anxiety, accessory muscle use, adventitious breath sounds. Probably what? Crackles. Now, if it is like a lung injury, you might hear which other one? Wheezing. What causes wheezes? It's like it's got filled with mucus, and so you got all the air going through a narrow opening, right? So but that's not fluid. If you had fluid in there and the air is going through it, it's like when you blow on a straw, right? And everybody does that. It bubbles. That's what you hear is crackling. What is this? I want to know how bad they're having to work for breathing. SpO2 respiratory rate, accessory muscles. You better be looking at that cardiac rhythm, because when they get this bad, they're going to dysrhythmias and die. Monitor their mental status. Listen to their lung sounds. We have to treat the cause. If it's got a burn injury and they haven't developed an infection, well, they're going to give them prophylactic antibiotics. Why would I do that with a burn injury? I'm going to give you antibiotics anyway. You're a huge. What kills 90% of burn victims? Infection. Did you have a question?
Oh no, I was just gonna say their number one response to protection for infection was their skin.
You got to treat the cause. If it is sepsis, we got to figure out which antibiotic to use. Why did I put this?
Because it helps.
So, it does help, right?
Because when you rotate it to make sure the mucus isn't moving out intentionally.
So if I'm laying on my back and I've got all these fluid in my alveoli, what does it mean to you if I said let gravity help us? So the fluid's back here, right? When I flip you over, where's the fluid? It has moved. You are letting different areas in the alveoli get what? Oxygen. I've only seen it, don't even bring it up at Tenova, because I had a doctor tell me we don't do that here. Guys, that and the high flow nasal cannulas, just Ms. Horton's opinion, is what turned around COVID. Especially that high flow nasal cannula. This takes a dedicated team effort, usually, because it has to be a special bed that you can prone the patient on. And you have to have respiratory therapy, making sure the tube's in place, making sure the ventilator's at, and the nurses, we have to, you see what I'm telling you, there's a lot of people in that room when we flip a patient over. Can we just leave them like that? No. So when they get ARDS, they will have bilateral infiltrates. And you will hear them say it looks like ground glass. There are diagnostic criteria. Hold on. There is not a question about the diagnostic criteria for ARDS, but I am going to mention it. So you've got your PaO2 and your FiO2, and they've got a ratio, and it's less than 300. Their pH has to be a certain level, and they have to have these bilateral infiltrates for it to be considered ARDS. ABGs, chest X-ray, chest CT, CBC. You see that patient is prone. Every time, when did I tell you the patient's going to code? When you reposition it and move them, that code cart better be in there, because that's not the time you need to be running down the hall. That's just the high pressure alarms and low. Guys, there are not test questions on this, but you're going to hear this. You might have a nurse in the ICU ask you what is their RAS score. just look at it and what is this for? Is to find out how sedated your patient is on the ventilator. Why would that be a good tool?
So they can figure out getting out or get more.
To figure out, can I extubate this patient? Or do I need to change their sedation because they ain't doing nothing? Most of these are a no-brainer. If they ain't breathing, they need to be on the ventilator. Basically, respiratory failure, they probably need to be put on the ventilator. What does this mean? Airway protection. What if I tell you they're a bad burn? An inhalation burn? Their airway is going to do what? Swell shut. You better intubate them early. We'll talk about that in the burn lecture. That's airway protection. They might not be having that much problem breathing when they come in, but they got soot all in their mouth, and you can hear that horse. You better get the airway card down there. It's not going to take long. Sooner or later, you won't even be able to get a 2.5 ET tube down, and you're going to wind up. Will a surgical crack work? Depends on how far that you might have just signed their death sentence. Airway protection, respiratory failure. So severe circulatory shock is going to cause what? Respiratory failure, respiratory arrest.
With the RAS score, what number is like the best? Like, is it the lower number or the highest?
Well, that depends on your
So if you're a 0, we're all, most of us, a 0. Alert and calm. -1, drowsy, light sedation, moderate sedation, deep sedation. And it's got like quantifiers out here. And if you are working in the ICU and one of the bigger ICUs, I would kind of recommend that you look at this. They should be doing this every day to figure out if they have too much what? Sedation on board. These are the ones that I told you need to know. Tidal volume, respiratory rate, FiO2, PEEP, and HIP. No, I just need you to know what it is, and when that alarm goes off, what can cause it. The last thing, this is important. If you run in there and that ventilator is making all this racket and is doing things that you don't understand and you're the only one in there, what are you going to do? Unhook. Don't pull the ET tube out. Well, what if they snatch your ET tube out? What are you going to do? Back to patient. Every student in here needs to know how to do that the day you step across that stage. You're supposed to know. You all took CPR. And if you just kind of step through CPR, you're just going to step up to an emergency you don't know how to handle. If you don't have any idea what's wrong, pull them off the vent and bag them. I know how to do that. Look it up, doctor. I will download this, but I'm also going to add to this the difference between a pneumo and a tension pneumo and a hemothorax. I think I've got an image that shows all three, because they're all three different. Pretty much they have the same treatment, unless it's not that bad, and then we might not do anything but monitor it. I know that was really quick. So when is the tutoring session? Thursday at 7. And I will be recording it.
No. What time do you have class at?
You said, are we going to the wing shop? I said,
We don't have a class after this.
I'll see you at
Oh, that's true. I have to go see. You're free today? Yeah. He is.